All right, so I just wanted to go, what? You cannot minimize, okay, whatever. So I just wanted to go over the Moodle page just a little bit. I just wanted to review, just because we have a few kind of different things happening in the upcoming weeks with guest speakers. So I just wanted to kind of talk out for a minute the sort of the procedure of how I envision it happening. So today we'll talk about respiratory diseases. I put in this oral contraceptive and bisphosphonate PowerPoint. It's only like 10 slides, I think. I don't know that I'll have time to go over it. And it's a new little mini PowerPoint that I added. So there aren't really a lot of questions on any exams or quizzes for that yet. There could be something for bisphosphonates, because that's been on previous PowerPoints. But as far as what's on there, mostly that's new. So what I think I'll do is I'll just kind of see how it shakes out today. I don't know that I'll have time, but do read through it. And then when the exam comes, anything that's on there that is pertinent ahead of time, I'll tell you, like, make sure you know this about this, or, you know, we'll kind of review back through it. And I might actually even have time when we have a guest speaker, because they have an hour. They don't take the whole time. They just take an hour, maybe an hour and 5 or 10 minutes. It depends on the person. And so there's usually time. So I have it there, but we might not get to it today. So we'll do the PowerPoint for today. There's a worksheet we may or may not get to. So next week, we will have a quiz on today's material for over respiratory. So we'll do that first thing. And then they go by doctor in pharmacy. These two guest speakers that are coming are super laid back and so funny and nice, but they tend to, instead of calling them professor, I think they refer to him as doctor. So we'll introduce him as Dr. I think it's Beggart, and he's lectured in this course, this topic for years. So he's really familiar with sort of the routine and what you guys need to know for and he's really, really nice guy. So he'll come in, I think, about 9, and he'll do his part. So this is where it gets tricky. And this is why I don't have too many guest speakers, because it's really hard to get 2 PowerPoints in one class. It's just, and I'd rather have more of the time go for the speakers. So he's going to do his PowerPoint. There's all the medications, and he goes into some physiology. So I'm kind of just going to take it off of his PowerPoint for the most part, but there may be a few things that I really want highlighted. And so I post a second PowerPoint that you need to listen to, but really you can rely on the study guides that have already been given, and then the guest speaker's PowerPoint. But you do need to go and I usually pre-record it, and it's usually not, it's less than a half an hour. So you do have to go in and listen to the second PowerPoint on your own time, but know that most everything is either on your study guide or for the guest speaker. But there may be a little bit of background information that helps kind of round it out, or that you may need for a quiz or an exam. So don't ignore that second PowerPoint, and I'll post that recording once I get it up there. And so that's going to be the same thing. So then we have a break. That's cardiovascular drugs. And there's a lot of meds for that one. That's probably one of the heavier weeks for medications. There's a lot of medications to know for cardiovascular. So that's next week. And then we have anti-infectives, which is like antibiotics and antifungals. So I'll do that one. And then we have another guest speaker, Dr. Fortner, and he's another very laid back, very funny. And he's doing GI, which is easier. GI it's fun to have him talk, because he's just fun to listen to, and he's just different speaker, and it's an easier topic. So that's kind of like, whoo, not too much. Pepto-Bismol, Pepcid, like GERD, and it's those kind of topics. Ulcers, there's a little bit of stuff that that you're going to have to know, but it's not as complicated as heart disease. So those right now are the only, and then we have an exam. So gastrointestinal, anti-infectives, antibiotics, and today's respiratory and cardiovascular. So those are the 4 topics, probably with a few questions on the bisphosphonates, which will stick in there somewhere. So that's what you have to know for the next exam. A lot of more medications will be on the next exam, but we'll make sure that we're talking about them and highlighting them so that you know what to go back and study for. Any questions on that at all? So just to recap, the guest speaker, there will be an additional PowerPoint recording that you'll have to go in and listen to. 20, 30 minutes at the most, but hopefully even less than that. Okay. So then I'm just going to pull up the PowerPoint for today and we'll go start on that one. I wonder if I saved it after I did if this does not look like what you have, if you downloaded it, I was working on it on Tuesday. So if for some reason something doesn't match up, I'll make sure that it's uploaded into Moodle. But I think this should be current to Moodle. Okay, so respiratory system and medications. So pretty much all we're talking about today, I'm going to try and be succinct. I know I always end up saying more words than I want, and that's why I always run out of time. But mostly, basically what we're talking about is rhinitis, so some kind of inflammation in the nose, whether that's allergies or a virus. And then we're going to talk about asthma and then COPD, which is a combination of bronchitis and emphysema. So those are the main topics that we're going to talk about. And so we're just going to do a little bit of sort of a little overview of lung anatomy, much more simplified than what you might get in a anatomy and physiology's course. So obviously we breathe in air, it goes through past our pharynx, trachea, and then our lungs branch off. We have tons of divisions of branching in the lungs. They go from the bronchi to bronchiole, so like from larger to smaller until they end at the alveoli, and there's just gobs of alveoli that are all surrounded by tiny little capillaries. And so that's where the oxygen exchange happens from the capillaries to the lungs to oxygenate the blood. So when we think about airways being surrounded by smooth muscle, what are some, if you think back to the last topics, what kind of receptors affect smooth muscle for one? And then there might be an answer that pops up there that you can see in the notes, but alpha 1, smooth muscle, and then what's the other one? Beta 2 for the lungs, right? Yeah, so those are 2 that, and we'll learn about a new one today, but those are ones that really will affect constriction and dilation. So when the muscles are stimulated, they contract. So that's some of these receptors actually dilate. And so that can be confusing. But I think, and this is coming out of the textbook, but what the textbook is talking about is if the muscle itself is stimulated, it will contract. So that's different than something working on a receptor. So different body processes will have different effects on the body. So if if a beta 2 is stimulated, you're going to get bronchodilation. But if the muscles themselves are stimulated, so like, asthma or something like that, you'll get constriction. So different elements will affect the lungs differently. But in general, when the muscles are stimulated, they contract and they narrow the lumen. And so then you get it's like a smaller opening. The diameter is smaller. So then of course it's harder to breathe, or you get less oxygen. And you can think of that with alpha 1 because that's constricting. Yeah. Well, I don't know about nerves because I don't think that we did, but you can think of like receptors maybe, or neurons, the receptors on the neurons. So if it's a beta 2, it has a bronchodilating but if it's at alpha-1, it's smooth muscle contraction. So it kind of depends on what is being stimulated. So if it's the muscles being stimulated, and that kind of goes more in line with alpha-1 in the lungs, smooth muscle contraction. But if it's beta-2 receptors that are being stimulated in the lungs, that has a bronchodilating effect. So it just depends on what receptor is being stimulated. And then we're going to learn more about a whole new one here as well. Yeah.
Are you recording?
I am. Yes. Although I was listening to my recording from last year, and I don't know how you guys, I'm like, I don't understand what you're saying. I'm like, I don't know how you listen to me. I should never do that again. Although it's supposed to help you like do better at speaking, but I don't know if it's going to help. So, okay. So this is a kind of a nice sort of summary chart to help you kind of see all the different receptors that are going to work on this respiratory system that we're focusing on today. So alpha-1, like we said, smooth muscle contraction. So when it's stimulated, this is all agonists, right? This is all like adrenergic agonists. So it's doing its thing. It's not being blocked. If it was being blocked, it would be opposite, right? So alpha-1 lung smooth muscle contractions in the vasculature, there is a response within the vasculature as well, because all your veins and everything, they're basically sort of smooth muscle, right? They expand and contract. So vasoconstriction of the blood vessels, and epinephrine works on alpha-1 quite a bit. So when we add epinephrine to local anesthetic, we get vasoconstriction around the area. That's where it's working on. Beta-2, we're going to, when that receptor is triggered, I was going to say, but that's not the right word. We get bronchostimulated, thank you. When that receptor is, we get lungs bronchodilation, like we said, and we also do get some heart response from cardiac contraction increases, even though we generally talk about beta-1, one heart, beta-2, 2 lungs. So that's the thing about all these receptors is you can get some response, but one response is going to outwin the other response. One response is going to be stronger, and then the other response might just not be as strong. So it doesn't mean that it doesn't affect it some, and so when they are developing drugs, they look for these strong responses for whatever therapeutic effect they're trying to achieve. And then on the vasculature side, we have vasodilation. So in general, the veins and vasculature, everything kind of opens up a little bit. So H1 is a new one. And this one works on a lot of things when it comes to our anything dealing with allergies or the respiratory system. So we have in the lungs, if H1 is stimulated, and just as an overview, you can write this next to it, almost every medication that works on H1 is trying to block H1. Because if you look at the things, the response, it's not really desirable. There's really not much there that's desirable. So in the lungs, bronchoconstriction, bronchial mucus and secretion, nobody really wants a ton of mucus in their lungs, and congestion, vasculature, yeah.
I'm confused a little bit because these are all parasympathetic, and so why would any of the receptors constrict the blood vessels?
The alpha and beta are actually sympathetic.
Yeah.
And so that's just it's how they, if you go back, it helps a lot. When you're trying to figure all this stuff out and get it straight in your head, I swear it helps a lot to go back to the beginning too. And that chart that shows like the brain and the spinal cord, and then it shows with the sympathetic and the parasympathetic, and it shows like, it's going to do this on this side, and then it's going to do the opposite on the other side. Some of them are not always super intuitive. It's almost a little counterintuitive. Like you said, like you're sitting there thinking, you're like, well, why is it constricting? Shouldn't it do the opposite? But when you put it into a scenario like, like if your body's trying to protect itself, or you're trying to, have, you know, a lot more oxygen or you don't need as much oxygen or whatever the scenario is, then it starts to make sense. But for these specifically, like why beta vasodilates and why alpha constricts, I don't really have like a great answer. That's just the way the body is. I don't know. That's where my level of knowledge kind of ends. I don't know why it does it. It just does. Okay, so with the vasculature, we will see more nasal mucus secretion and congestion, hives and edema, and that's just related to the vasodilation in those areas, and so it opens everything up to more of that. So a lot of times we'll actually have for like nasal decongestion, things will shrink. It'll try and vasoconstrict it so that we kind of cut off that supply to try and dampen down all of that excess mucus or excess secretions during whatever kind of reaction you're having or viral episode that you're experiencing if you're having a virus of some kind. And then the eyes, localized vasodilation, redness. So those drops, you know, that you take to make your eyes not red, they're a blocker. They're trying to constrict the vasculature in the eyes to try and reduce vasodilation there as well. Leukotrienes is another receptor. I don't remember if we talked about leukotrienes in the second PowerPoint or not, but in the lungs, again, if a leukotriene is stimulated, then we have bronchoconstriction, yet again, another probably non-desirable effect, especially if you have asthma or allergies or a cold or something. And so a lot of things that work on leukotrienes are going to be blockers. Okay, I already said this slide. These are just the diseases we're going to talk about today. This is just prevalence. You don't get to, I don't test you on prevalence, so I'm just going to skip that. Etiology. So when we talk about rhinitis, which is basically just rhino, you know, it's like the nose, right? That's the root word. And then itis, anything that itis is inflammation. So inflammation in the nasal area. And so if we're talking about an allergy or allergic rhinitis, the reactions, and this stuff is, you will be tested on questions like this, like what can trigger allergic rhinitis? Tons of things. It's different for anybody. You know, everyone has their own special, unique blend of what they're allergic to. But in general, pollens, mold, dust, animal, dander, you know, ragweed. There's just, you know, lots of different things that people are allergic to. Different trees, different regions of the world. You know, you can be super allergic to what grows on the East Coast, but not allergic to what grows on the West Coast. And who knows what is just some, you know, thing that triggers your immune system. Viral rhinitis, or the common cold, is different. Of course, this is a virus that instead of an allergen, it's a virus that triggers all these symptoms. I put a little bit more information in the notes just for interest's sake, but just to sum it up, there's over 200, there's probably more by now. I don't know. There's probably, I would think there'd be thousands of different kinds of viruses, but lots and lots of viruses. Generally, we're infected by droplets or aerosols. You guys, this is kind of old hat from the past couple of years. We've heard nothing but how to protect yourself from viruses. Rhinoviruses, coronaviruses, adenoviruses, and RSV, respiratory syncytial viruses. Those are all the most common that are just constantly mutating and being circulated. And in general, even though they talk about it now, but I don't really get it, because in general, you can't vaccinate for a common cold because of its incredibly high mutation. So there's never been a vaccine for RSV. Little babies are very susceptible to it, little babies, like newborns, and can give like some kind of a monoclonal antibody sometimes to like preemies to protect them, but there's never been like a true vaccine, but they are trying to develop it now. But in general, historically, the common knowledge is you just can't. There's too much replication. You'll never catch up with the strain that's out there. Vitamin D, though, side note, do a little research on that, because there is really good randomized clinical trials, the kind of gold standard of clinical trials that shows that vitamin D, like a good dose of vitamin D, especially for us up north in the winter, is massively beneficial for keeping you like from getting really sick. Like you might still get a cold. I still got a cold, but you may it'll keep you from getting really sick. And there's literally a vitamin D receptor on almost every cell in our body. So it's like there's research for cancer and cold and just your whole immune system, vitamin D, and you can't get it by eating more apples and oranges and healthy food. You just can't you can't get it that way. So super important supplement. So do your own research. I'm not your doctor, but if I was your mother, I would make you take it. Okay. So now we'll talk a little bit about specifically rhinitis or allergies. I mean, so here we have what's called a mast cell. So it's just a cell, an immune cell in our body. Everyone has them floating around. They're not harmful, but they can start to be kind of pesky when this reaction starts to occur. So on the mast cell, you have all these little Y-shaped antibodies, and they're just sitting there kind of waiting to get a signal. And then inside of the mast cell, there's a bunch of histamine. And histamine is, again, like normal for our bodies, but if we get too much, our body can overreact. It's just part of the immune system, and our immune systems can overreact to things. So that's basically what happens. A little bit of pollen floats in, lands on one of these little Y receptors, and once it attaches, it signals the mast cell to release histamine. And then the histamine does all the stuff, makes your eyes itchy and watery, makes your nose runny, sneezing, all of that stuff is histamine, and it's releasing it. So all these drugs try to basically block that process in one way or the other to try and eliminate all that misery. There's a video in here that you guys can watch, and I think it's a Khan Academy, and he just does it's a little slow, and especially in the beginning, you could fast forward through it, but he does a really nice job of walking through it. And in the video, he talks about the irritated nerve endings making you sneeze. And early in the week, I was like sneezing like 30 times a day, and I was like thinking my nerves are irritated. That's why I'm sneezing so much, is because my nerves are irritated. So it's kind of fun to know exactly what's happening during these processes. So these are all the signs. We already talked about them: congestion, runny nose, itching, sneezing, mucus production. This is the video. It's about 10 minutes, and you could probably easily fast forward the first 3 or 4. And it just goes through the process. He just breaks it down in a really nice, and I think Khan Academy is sort of, isn't it high school level or is it college? It's high school. So it's nice because it breaks it down very simply. So when things are presented a little bit like maybe more steps than, and then you go back to basics, sometimes it helps. It's like, oh, okay, now, I see all the steps. So I like watching them personally myself. But so that's in there. And I think there's also some just in the Moodle. Okay, so treatments, you basically you do your best to avoid allergens, and then the medications that we'll talk about as well. And just as some kind of critical thinking, so if you have a cold, what might you go to the store to try and get to help with the cold symptoms? Sudafed, NyQuil, soup, yeah. Ginger tea, that's what I would do. What, Mucinex? Yeah, exactly. So all of those things, decongestants, anti-inflammatory, pain medications if you're having discomfort, Dayquil, things to help with itchy stuff. What would you not take if you have a virus? Antibiotics, right. That'll never work. An antibiotic, there is some research on, I want to say it's like the Z-Pak, the erythromycin, Z-Pak, I think that's with how it works with some viruses. There's a lot of anti-inflammatory properties. So there's some kind of weird little things that they study. But in general, if you have a virus, you're not going to go to your doctor and say, I need penicillin or amoxicillin or something like that. Your body's not going to respond to the antibiotic. Okay, so when we're talking about these drug families, we're basically going to talk about drugs that either slow the reaction. So that's going to be our mast cell stabilizers, they call them. And I put blocker in parentheses. I don't know that it blocks the mast cell, but it sort of stabilizes it. It's more of a blocking mechanism, so that's why I put that there. But it stabilizes it just so it doesn't have a tendency to release the histamine as easily. And then antihistamines, which are definitely blocking that receptor. And then it can open things up, decongestants, or calm things down, anti-inflammatories. So those are all the mechanisms in general, to summarize, of the different medications. So for a mast cell inhibitor, you're going to do this to either prevent or treat the symptoms. And then the mechanism of action is it inhibits the release of histamine, and it has some anti-inflammatory properties. And this is going to be earlier in the process. So this is going to be, so instead of it being like something that will just block histamine responses, it happens a little bit before to try and keep the whole cascade from happening in the first place. But it doesn't instantly work. You have to take it sort of preemptively, knowing that you have a risk of this, and because it takes a couple weeks to work. So adverse effects can be nasal burning or stinging, and localized in the nose region, the nasal region. And then an example of a mast cell stabilizer is nasal crom or cromolyn sodium, and it's over the counter and it's inhaled. For antihistamine, again, we're preventing and treating. It's the mechanism of action is it's blocking the H1 receptors and blocks histamine from binding to the H1 receptors. It's blocking the receptors. And there's a couple of different, there's first generation and there's second generation. And you'll find this in different medications. And it just means that they discovered something and then they just kept searching. And then 10, however many years later, they found something similar, but maybe it had less side effects or something like that. And so then, if it's a similar drug, then they might call it first generation, second generation. So equal anti-allergic efficacy for both first and second generation, but second generation has less side effects. If it's highlighted in yellow, very good chance you're going to have a quiz question or an exam question. So that's why some of this stuff is highlighted. What's the what? I have no idea. Okay. I don't know. I think it's just probably. That's probably what it was. Amy, this was her course. She taught this course, Director Copeland. She taught this course for 9 years. So I got her whole slide deck and I've added things and changed it, but the basic format and some of the pictures are, and a lot of the content too, is hers. And so sometimes like, well, but it's probably because it's a blocker. So that's a good guess test. Yeah. So adverse effects, we're always going to want to think of all of our drugs in terms of what generally is it being used for. Mechanism of action is important for this class. You're not going to find it as prominent when you're sitting there chairside with a patient being like the mechanism of action of this drug, but you do have to know it for this class and you do have to know it for the boards. But chairside, generally, what is that patient taking that medication for? And then interactions, drug interactions, and side effects. Those are going to be major things that you always really want to know. So adverse effects for antihistamines, xerostomia, dry mouth, that's just going to come up. It's a constant for the rest of this class. There's so many drugs that cause xerostomia or dry mouth, and we know that that's a problem for caries risk and perio too. So anticholinergic effects, that's an umbrella term, and you'll see that a lot as well. And in general, if a drug has anticholinergic effects, they do it. A result of that is dry mouth or reduced salivation, reduced lacrimation, so dry eyes, and then reduced urination and defecation. So all those four things just go with anticholinergic medications. So just kind of, that's just something you want to just build right into your brain cells, because that's going to it's going to come up with other medications throughout this whole course. And then drowsiness and sedation varies depending especially on first or second generation. So first generation, we have Benadryl. That's classic. Probably everyone's taken Benadryl, right? And what is the one thing you think of about Benadryl and a side effect? Oh, sorry. Yes, question. Sorry. Yes, but you sleep. Oh. It is, it's a lack of those. Yes, good clarifying question. Thank you. So anticholinergic means that all of these things, so think about cholinergic is your parasympathetic, and it's when you're relaxed, right? Rest and digest. So if you're digesting, you're pooping. If you're eating and you're enjoying your food, you're salivating. So those are things that can kind of trigger that to help you memorize, right? If it's anticholinergic, you're not resting and digesting, so you have less saliva, less lacrimation, less urination, defecation. So you kind of have to go back to that rest and digest versus fight or flight. So if it's anticholinergic, then you have a reduction of all those. That's a very good clarifying question, because that is something you absolutely need to know. So yes, so like we said, first generation Benadryl and high sedation and high anticholinergic effects. So dry mouth, dries you right out, puts you to sleep. So those are undesirable side effects that they were able to mitigate with the second generation, loratadine and cetirizine and whatever this one is. But we all know it as Claritin, Zyrtec, and Allegra, right? Those are very common brand names that we see in the store. They're trade names, brand names, and we tend to say those more than loratadine. I've had the doctor refer to it when they prescribed it before. So I'm sure it just depends on the practitioner, but a lot of us recognize these brand names. And you can see everything with the sedation and the anticholinergic is lower. I still get very dry if I take something like Claritin. It still affects me quite a bit, so I tend to not if I can help it. Everyone's different, obviously. Here is just another chart. Here's another chart that shows those same medications and just the antihistamine efficacy. So how well it works, the anticholinergic activity, and then the sedation. And you can see Benadryl is high on all of them, but like Claritin is high with the antihistamine and lower with the other two. So just another way of visualizing it. If that is what I added on Tuesday. So if you don't see it there, did you see it? Is it on yours?
I downloaded it.
Oh, and it's not on there? Oh, weird. Okay. I'll make sure that I might have to refresh my Moodle. I don't know why. Sometimes it does funny stuff. Okay. That I might have added one other picture, but they're sort of the stuff that I added on Tuesday is not like new content. It's just like another way of looking at it. But I'll make sure that it's after class, I'll go in and I'll like reboot it, make sure it goes in. So decongestant, sympathomimetic drugs. And so this is just another way of saying adrenergic medications. And I just put it in there as you can harken back again to the autonomic nervous system and those phrases just to kind of keep those words in there. Anticholinergic, we use a lot more than the sympathomimetic. So I just pop it in there just to remind that that's what we're talking about. But so this is to treat symptoms. And how the mechanism of action for decongestants is vasoconstriction in the nasal mucosa. So an alpha-1 adrenergic receptor is gonna be the response. Vasoconstriction. Did I say that backwards then earlier? I think I might have. Yeah. I just was wondering, alpha-1 agonists act as nasal decongestants by constricting blood vessels. Yeah, oh no, that is what I said earlier. Okay, I was talking about the vessels closing down when you take a decongestant, or did I say open up?
No.
I said close down. Okay. Well, it's on the recording, so there's proof, I guess, somewhere. But anyways, so it does vasoconstrict to help kind of cut off maybe you can think of it as cut off the nutrient supply or something to help with that excessive mucus and secretions that you're getting in those areas. And it works on the alpha-1 receptors. Adverse effects, again, here we have xerostomia. You can have some localized burning, topical burning within the nose. Increased blood pressure and heart rate, that's systemic. So that's, probably not as likely if you're using something very local, but some people can be very sensitive. Everyone reacts different to medications. And so that's a possibility. And then in general, short-term use, because there is a rebound for some of these medications. If you use some of these medications too long, you'll get less good results, and then it kind of just doesn't feel as effective. So some of these you have to use like at the height of it, like maybe for a couple days and 2 days or something, and then try and back off and see how. But if you just keep using it for like 2 weeks in a row or something, it's going to lose effectiveness. So some decongestants that we know of or that are common to us is Sudafed. We have the over-the-counter pretty much for all of this medication here. Afrin is another type of oral intranasal decongestant. There's all different brands, but I probably should have made this one red as well. I think I meant to make Afrin red. But if it's not on your other list of medications that you have to memorize, and I'll just leave it. I'll double check. But Sudafed, pseudoephedrine, and phenylephrine. These are ones that this is intranasal and this is oral. So, one's like a syrup or a pill, and then the other one is a spray. So that's just different routes of application. And of course, you do know, pseudoephedrine was prescription only for a while because people could make, illegal drugs with the ephedrine and stuff. So, and of course that, has quite an effect on the heart if it's orally, or especially if they've messed with it to turn it into some kind of a more potent drug. But now you can get it back. It's become available back without a prescription, but for a number of years, I don't know, 15 years was it, or 10, 15 years, you couldn't get it without a prescription. So intranasal corticosteroids is another one. This is your anti-inflammatory. So this is just trying to calm down the inflammation because that inflammation is causing a lot of the discomfort. So medications for that is going to be like over-the-counter Flonase. There's also prescription as well for that, probably a higher dosage, I imagine. Veramist and Nasonex, these are prescriptions and different chemical formulations. And these are all to treat inflammation. They do different things. They inhibit mast cells and the mediators like histamine, leukotriene, and the prostaglandins. So all of those things are part of your immune system that are just triggering your immune system. And when your immune system starts really reacting, you get a lot of inflammation. That's just sort of a natural cascade of how our immune systems work when they go out of check. So this helps with that inflammation. And it can take a little bit to really kick in and start doing its thing. So maybe a couple days, and some adverse effects there is stinging and burning, dryness. If it's just localized, like inhaling or intranasal, and it's short term, you're not going to have to worry so much about some of the long-term corticosteroid sort of side effects. But if somebody is on something for a long time or using a lot of it, they may have to worry about it. But generally, these types of medications are not used that long term, I wouldn't think, unless they. Do you?
My boyfriend does.
Oh, he does? Because now, is it allergies for allergies? He just has like,
Sinus.
always has sinus issues. Yeah. For years, has he been doing it? My husband used Flonase for like his whole high school. And then because he was super allergic to what was growing on the East Coast. So here's a chart for, this is just to help you guys with studying the drugs. So you have your drug here. The how is like the mechanism of action, and then any adverse effects. So fortunately for you, the main adverse effects for a lot of these are dry mouth or maybe localized stinging and burning. There might have been a few other things here and there, but those are like sort of the main things. So there's not a ton of side effects that you have to worry about. But this is, fill out this chart, make flashcards. That's another great way to help you memorize the medications and what category or what they'd be used for. And test each other or have your roommate or whoever whoever is close at hand, easy access to study with for these, especially once it starts building up. You have, this PowerPoint and the next one and the next one, and you have, a good chunk of medications that you want to know what the general category is. It anti-inflammatory? Is it this? Is it that? Is it high blood pressure? Is it, you want to know more specifically what is it for, and then the mechanism of action. Those are the main things. So just have kind of a little critical thinking exercise. A 28-year-old female is returning for a routine dental cleaning. A few days ago, she came down with a cold. Her symptoms include watery and itchy eyes, sneezing, and nasal congestion. She's not coughing or have a fever or anything. She's been taking Benadryl every 4 to 6 hours. And it's helped with her itchy, watery eyes and the sneezing, but she feels kind of zoned out, and she's still congested and hasn't been sleeping well. She breathes through her mouth, and so it's kind of, and that she thinks that's why she has dry mouth, is because her nose is stuffy and she's breathing through her mouth. So explain why Benadryl helped her itchy, watery eyes and sneezing, but not her nasal congestion. That's a hard question. I think that's a hard question. Yeah. I think the main point that they're trying to get at is that it's not just allergies. So she might have some symptom relief here with taking Benadryl, but it's not just allergies. So that's why it's not helping all of her symptoms, especially her congestion. So it's sort of like, it's working on maybe some of the receptors, but that's in general the overall take home, I think. Which drug may be better for relieving nasal congestion? Instead of taking like an antihistamine drug, maybe what kind of a drug should she choose to take instead? Like some kind of a decongestant, right? Or an anti-inflammatory too, maybe both. But a decongestant would be a good place to start, and then maybe an anti-inflammatory drug. And then what may be causing her dry mouth? Yes, she's probably breathing with her mouth open. That definitely does some, but what's the main culprit? She's taking Benadryl every 4 hours. And she feels zoned out. That's no wonder. So it's making her tired, and that's really drying out her mouth. So you can help your patients understand that if you have someone that's like, I'm taking Benadryl and this is happening. What drug may be better for relieving her itchy, watery eyes and sneezing that would be less or would minimize the dry mouth? What could you recommend to her instead? Yeah, Allegra, Claritin, Zyrtec, something like that. Okay. So now we'll talk about asthma. So here's another prevalence. I'm just going to sort of skip over that because I don't really test on prevalence, but I do to ask questions about pathophysiology. So this slide and the next slide. So you notice how they're numbered. There's these steps, 1, 2, and then 3, 4, 5 on the other slide. So those you should be familiar with. You should kind of study these steps. And this is sort of the process of asthma. So when somebody has asthma, the first thing they have inflammation. And underneath the inflammation category, we have these these receptors that are being triggered. So the T lymphocytes, the eosinophils, these are all white blood cells that are involved in the inflammatory process. So these are all sort of overreacting, leukotrienes, and then mast cells. So if somebody's asthma is triggered by a dust or, you know, something like that, some kind of an irritant, then these things are going haywire. So that's the first step. We have airway inflammation. So you want to know these steps. Then there's mucus production, retention, and plugging. And that just means that you start with like more, so the airway's already narrowed from inflammation. So you already have a little bit of narrowing. And then on top of that, inside, you start to get a mucus production. And the plugging just means that little the alveoli and stuff, they start to actually get like filled up and plugged up with the mucus and stuff. So you're gonna lose even more open space for oxygen exchange when you get the narrowing of the lumen, and then you get this gunky mucus buildup as well. So then on top of that, 4 is bronchospasms. That can be mediated by the beta-2 receptors. And do we want to block them or activate them? Activate them, right? Yeah, because beta-2 in the lungs, bronchodilation. So, and then the later, so this is kind of like a later cascade. Hopefully things will get sort of improved earlier on in the pathophysiology, but you can also have lung hyperinflation. So they can't, the person can't express or exhale. And so all the alveoli sort of puff up and are filled with oxygen, but then they like can't do anything else. They can't take in fresh oxygen, and they can't release what's in there. So it does this air trapping, like overfilled balloons that are just like, meh, and they just can't do anything with that. And then at the end we have airway remodeling in chronic asthma. So remodeling is sort of like in perio. Have you ever heard anyone who's worked in a perio practice talk to the doctor or a dentist, any dentist maybe, talk about like the bone remodeling, you know? So it's just like changing in the structure. And it's not typically like a good thing really, because it's a lot of times it's like loss of structure. Yeah. Beta-2 when it's activated. Oh, I don't know why I have blocked.
Beta-2 when it's activated, opens the airway, but during that asthma attack, the opposite happens, and the bronchospasm opens.
Oh, I think I'm meaning that the asthma is blocking it and we want to open it. Maybe that's what I meant by blocked. I'll take the word out blocked because that would be confusing. But I wonder if that's because you are going to have the bronchospasm during an asthma attack. It's going to be constricting. And then a beta-2 agonist is going to open it up. I don't know why I have blocked there. I will delete that or cross it out because I'm not sure what I was thinking. Maybe I was thinking that asthma is like blocking that beta-2, but that's a confusing thing. What you really want to know is beta-2 is going to open it up. We're going to take medications that are going to work on that beta-2 receptor. Yeah.
Actually block the beta-2 receptors.
Are you asking me that? Yeah. See, that might be why I wrote the word blocked there. But now I'm like second guessing myself and I'm not sure. But what I definitely want you to know is that the medication fixes it and opens it up. So definitely what happens, what we know for sure, is that we have bronchospasms, so a closing, and then the medication works on those receptors and in an agonist way and opens it up. But it could be the first thing you said could be true. And I think maybe it is, and that's why I wrote it there. But now I want to double check myself. Is that what it says in? Oh, okay. So that's probably why I wrote it there. Okay, good. Oh, good. We're all relearning and clarifying. They're blocked. Okay. Good to know. That's what we want to know. Okay. So here are some risk factors. There's all kinds of crazy risk factors. Like in the notes, you can see thunderstorms can trigger asthma attacks. Don't ask me why. Here's another highlight. So here's another thing that you are going to need to know for, and does yours under mild intermittent, does yours say symptoms 2 times a week? Okay, so this definitely, I don't know why this didn't get updated in yours, but it didn't. So I will do it after class, but it is less than 2 times a month. So mild intermittent is far less frequent than mild persistent. So somebody who has a mild intermittent, they may not even come with their rescue inhaler because it's like, oh yeah, it happens like, or it happened like once a year ago, or they just don't, or maybe it's more frequent, but maybe it's so infrequent they don't even really bother to bring their inhaler because they just feel like nothing bad ever happens. At Give Kids a Smile, one of the seniors had a little girl who came in and she had asthma, and they wrote it on the medical history, and her mom had left the inhaler at home, which is not uncommon if it's not like something that you, again, like worry about that much. And so she said, oh, can I bring her back and start treating her? And I said, no, they have to have their inhaler because we have aerosols and there's funny smells and things in the clinic and in the operatory. So if anyone writes it down on their medical history, they really have to have brought their inhaler with them. That's kind of like a have to thing. So mild intermittent 2 times or less a month. And it just isn't really bothersome. It's waking them from their sleep, maybe less than 2 times a month. You can still call it intermittent, but it should be much more infrequent than if it's persistent. It's more of a regular thing, regularly using their rescue inhaler, maybe taking a systemic medication or something. Symptoms more than 2 times a week, awakening. I wonder if that's supposed to be less than, I have to double check this now. I'm going to double check this slide, and I promise by the end of, within a couple hours, it'll be absolutely accurate. But now I'm looking at this going, is that supposed to be less or more than 2 times a week? And then awakening from sleep, at least they have to have, in order to be go into the persistent category, they have to have it wake them from sleep at least twice a month. And then you have a more moderate, symptoms are pretty consistently like regular, maybe almost daily. And then severe persistent status asthmaticus. You can think of that sort of in terms of like that status with epilepsy. Oh my word, it's just left my brain. But epilepsy has another one where it's like major seizuring for like an extended period of time, like 20 minutes. And that person has to go to the hospital. So when we're at that sort of a status with status asthmaticus, they need more intervention, EMS, hospitalization, far more severe. Signs and symptoms of asthma: wheezing, coughing, difficulty breathing. Dyspnea is difficulty breathing. So there's terms that you're going to see throughout the course and in special needs. You might have seen them in medical emergencies. But these terms are like kind of medical terminology, and they'll pop up on random exams and quizzes and national boards. So whenever as you start to go through the program, just sort of keep track of these sort of new terms, but they're just medical terminology. Different, like difficulty breathing is layman's terms. You'll say that to your patient, but dyspnea is like the medical term. Yeah. Oh, for which one?
For the last slide.
Oh, what does it say? Does it say the same?
Intermittent 2 days a week or less.
Intermittent.
2 days a week.
See, that's contradictory then to because I have an updated textbook. That's why I was looking at my slides early in the week, because I got a brand new textbook and it just got published. So I was cross-referencing, and they say a month. So, but our textbook says a week.
So it says 2 days a week or less, and awakening less than, and then Mast more than 2 days.
More than 2 days. So this slide is right to your textbook. So that's good to know. That's good to know. So that it's, but yeah, although this, I have to say, I want to find a third source, because the new textbook, which is, just published, it definitely said month. That's why I went in and changed it, because I was like, oh, month, okay. So I'm gonna look at it and look at another source, like an asthma source, like a government asthma source or something, and see if I can find another definition, see which one it matches up with. So just put a little pause on this slide, and I will do just a little research after class, make sure I got whatever, because that's definitely contradicting each other. So your textbook says week, which is, but then the new one says month. So now I don't know what, I want to make sure you guys have the right input. Okay, here's just a picture of an x-ray of a normal chest and an asthmatic chest. You can see just a lot more white, things are closing down. And then this is just an animation video for asthma, so just another little resource. You can click on that and watch that. So if you were a medication treating asthma, we've kind of already talked about this, but if you were a medication treating asthma, how would you work to eliminate the asthma attack? You would, did I hear, and did someone say inflammation? So what? Steroids, yeah. So steroids, anti-inflammation, and then what was the receptor that we were just having a big discussion about? Beta 2. So a lot of the inhalers are going to be beta 2 agonists, and then a lot of them are combination beta 2 and anti-inflammatory or corticosteroids, inhaled corticosteroids. So those are like the main mechanisms. There's also different modifiers for, leukotrienes and all these other receptors, but those are two major ingredients for treatment of asthma. So we want to eliminate the triggers, of course. If somebody knows that something can trigger an asthma attack, they want to try and avoid that trigger. And then there's relievers, like the rescue inhaler is a short-term reliever, and then there's controllers and preventers. So if somebody is in the persistent, like moderate persistent, they're probably taking maybe a systemic pill of some kind, or like a regular dosing of some kind of an inhaler that's more of a preventer or a controller of the reaction to keep the lungs calm. But like it says here in the notes, we're not going to go into the medications quite yet. We're just going to talk about COPD, because a lot of the medications that they use for asthma, they also can use for COPD. And this is yet another sort of contraindication I found, or contradictory, I guess is a better word, in this new textbook, because it had a bunch of medications for COPD that didn't. So I was thinking for next year, I might have to restructure this a little bit, but we're still going with this for this year. And it still gives you basically the information I think that's really the most pertinent. So for COPD, the biggest thing for you to, let's take a little break first. Let's take a little stretch break, because I'm sure your brains are like full up with respiratory. 9:30, we go till 10:20. Do we? 10:20? Okay, let's just take a 10-minute stretch and bathroom break. We'll come back at 9:40. Someone will have to remind me to press record again, because I'm gonna pause it. All right, so we'll get started again. This handout is, I don't know why, I was just talking to Vince about this. I don't know why there's a stomach on it, because we don't do GI for a couple weeks. So just ignore the stomach. There are some H receptors in the stomach that medications work on. So it will come back. So you can save it maybe for later. You can just put this in with your packet of study guides, but answer these questions basically around the bronchioles and the lungs in relation to asthma. So these are just some questions to help, because this is type of material you need to know for the quiz and exam. Identifying the receptors H1 and beta 2. You can ignore the H2 on each organ, and so you can ignore H2 in the stomach. Would it be an agonist or an antagonist for beta 2 and H1? And then what would it do? What are the 3 steps involved in an asthma attack? And that's going back to that pathophysiology, the first 3 main things that happen. And then if you were a medication, how would you work to eliminate an asthma attack? So just getting you to go back and look at the medications that we'll cover here in a minute. So those are just that's just a worksheet for you to help you think in terms of what kind of questions might be on a quiz. Okay. I was just going to share with you guys, yesterday I took my, I have 2 puppies, and so I took my older puppy, he's like 7.5 months old. I took him in to get neutered, and poor guy. And he's terrified of floors that don't have a rug because he just slips incredibly. I've never seen a dog slip so easy in my whole entire life. And so he's got long legs. He's a German short hair pointer, and he's got long legs. And so he comes in and there's like a little mat right here, and he's on the, and he just shakes and cries. And I had to carry him to like the back. And so then when I went to pick him up after surgery, he was a little dopey, but he was still like just as terrified. And the lady was like, walk with him across the floor, like at his level, like go down like this. So I literally like duck walked, and he followed me. It was like I was just like walking, and he was he is the biggest baby. I have never seen a dog as such a big baby. Oh my gosh. But I thought that was hilarious. Like he literally he followed me as long as I was walking crouched down. Because he's heavy, he's big. He's like 70 pounds and he's not even full grown. He's big. He is a big dog.
Is there a whole house carpet?
So downstairs we have like linoleum, but there's a big area rug and then there's a couple area rugs. So he has a room where I kennel him. And so coming out of the room and down the hall, he's always like, woo, and he's skating. I mean, his legs are like going, but he's used to it. So he knows, and then he goes to the carpet. Like we have a big like area, big area rug. So he spends all his time on that. But at the vet, it was like a big distance, and it was all, and he's so terrified of the floor. It's just hilarious. But I just thought if anyone else has that problem, just walk like a duck and maybe they'll follow you. Okay, so we'll go back to COPD. So the big thing to know for the, this is prevalence. We're gonna, I always read this stuff. It's good info, but I won't quiz you on things like prevalence. But does that say this bronchitis but this is one takeaway that you definitely should know when we're talking about COPD, because you'll have a question like this, I'm sure, is that it's a combination in general. When you talk about COPD, the individual has a combination of emphysema and chronic bronchitis. So that's an important point that you do want to know. And a lot of times it's obviously associated with cigarette smoking, but it can, other things too, other lung injuries can occur from, environmental, work, if someone works in certain environments, and they can have some kind of long-term, chronic problem that will end up with emphysema or chronic bronchitis as well. But generally speaking, we know that a lot of times it's smokers. I'm not going to test you on this etiology stuff either. This is just more sort of interesting information if you want to know sort of what's happening there. This image is also new. I'm sure you don't have it now because I added this. This came out of the new textbook. And I just like the different animations that they'll use, but it shows, all the alveoli, and then how basically they burst. And instead of having all these little air sacs, when somebody has COPD, those air sacs get destroyed and they burst, and then they have these bigger areas. So the whole oxygen exchange mechanism of our lungs is not working the way it's supposed to work. And there's destruction or necrosis. So pathophysiology of this just kind of goes into it again. Pretty much we have the chronic bronchitis, changes in the bronchial wall. There's a thickening of the wall, so it's not gonna be as elastic. And then there's increased size of the mucus glands. So there's a thickening of the wall and more mucus. Anytime you have those things, when you think of the lungs being supplely able to expand and contract, and you don't want a lot of mucus, so obviously those are bad things. Obstruction can be caused by a narrowing of the airway, increased sputum production, mucus plugging, so things just get literally plugged up with mucus, and then the collapse of the airway too. So these alveoli that aren't gonna hold their balloon-like shape and filling up and closing down with oxygen, and they'll just collapse. For emphysema, a lot of time it's smoke injury. This slide, you can make a note that you don't have to know about these like neutrophils. There's some notes in the side that talks a little bit more, puts some more detail into it, but I'm not going to test you on any of this. Just in general, there's more of a because of the smoking, it triggers this cascade of damaging events from the neutrophils that end up damaging the lungs. And it's the body sort of compensating. And then sometimes when the body overcompensates, just like you can think of like periodontal disease, like the body's trying to fix something, but because there's this chronic inflammation, you end up losing bone and all the supporting structures. So that happens in any kind of like a chronic inflammation scenario. The airspace is enlarged, there's loss of elasticity, and the airway collapses upon expiration. So yeah, this just kind of an overview, but I don't really test you guys on this pathophysiology. I highlighted the asthma. I highlighted the asthma pathophysiology because you will get tested on that, but this is more just sort of, there's a lot of details with what's actually happening like on a cellular level with the neutrophils and why it gets triggered with someone who smokes. It's interesting to know, and if you have like a passion for smoking cessation, it would be beneficial to learn more of the details so you can talk to your patients about it. But really, it's a lot of information that I feel like just we don't need right now because we have a lot of other information that we need to focus on. So I'm not going to test you off of this slide. That can probably be your takeaway. And this is probably the slide. You're not going to be tested on this slide. And this is actually probably more of the slide that I was thinking of too, because this actually goes into a lot of detail of how the cascade of events of a chronic smoker can end up with lung disease. So it's interesting. It's nice to know. It's not have to know. This is just more sort of supportive information with the pathophysiology of COPD. So signs of COPD, chronic bronchitis, a lot of coughing, sputum. Patients are often more sedentary. They don't move around a lot. They're not going to be like an athlete. They're more, they sit maybe more, possibly overweight. Cyanotic is like a bluey, maybe blue fingernails, maybe bluish lips. They're just not getting as good of oxygen exchange. Edematous, so maybe swelling somewhere in the especially the lower extremities, and kind of a breathless. They're just kind of always out of breath as they come to sit in your chair, from walking from the waiting room to your chair. Maybe they're just, breathing like heavy. For emphysema, they're going to have difficulty breathing in general, dyspnea, and enlarged chest. So they might have like this barrel-chested look. And then weight loss as the disease progresses, so later stages of the disease. And then cyanosis usually is not seen in just emphysema, but it can, if it's obviously a COPD, then it may be seen. So ongoing cough, or a cough that produces a lot of mucus, shortness of breath, wheezing, whistling, chest tightness and heaviness. These are all sort of repeated symptoms that you already saw in the previous slides. So treatment, there's no cure for COPD. Once that sort of damage is happening, sometimes they can, it can be very mild, and some of the symptoms can actually go away. My dad smoked for years, decades, and he had very mild COPD that he had, the symptoms were prevalent in Maine when he was living in Maine, but when he moved to Arizona where it's dry and, you know, hot, the symptoms went away, but he was fortunate. It was very mild, but so sometimes it can happen like that. But if it's more severe, then usually the symptoms don't go away that easily. Smoking cessation is obviously really important if somebody's just starting to have symptoms or see destruction. If they have a chest x-ray and you can start to see destruction, obviously the sooner they quit, the better. There is things like pulmonary rehabilitation, oxygen therapy, very severe cases, surgery and lung transplants. And then there's pharmacological management. So inhalers and different medications to try and help with some of the symptoms. So medicines to treat COPD symptoms include bronchodilators and a combination of bronchodilators and steroids, very similar to asthma. And this is just a slide on the cost of smoking. Just more of sort of an interesting to note, not really have to know for an exam or quiz. Okay, asthma and COPD medications. So to kind of summarize it up, for both of the conditions, you can see that beta-2 agonists are going to be a major drug family that's going to be utilized for asthma and for COPD. Corticosteroid medications as well, so dealing with the inflammation from both asthma and from COPD. And then for asthma, we have more like a leukotriene receptor antagonists or blockers, so leukotriene blockers. And then there's a variety of anticholinergic medications for COPD. So there is some different, and also like somebody who has COPD or emphysema, you may see them carrying around oxygen. You don't really see that with someone with asthma. They don't really carry around oxygen. So there are, you know, there are differences, but there's also a lot of overlap. Okay, so for our beta agonists, we have some different categories as opposed to if they are a short acting or a long acting. And sometimes these can be referred to as LABA, long acting beta agonist, LABA, or SABA, short acting. Short acting, are you a short acting beta agonist? Short acting beta agonist is SABA, and then LABA. And so you'll see that written in, you know, just different places. Like if you go to, you know, I don't know, different resources, they may simply just refer to something as a SABA or a LABA, and then you're like, what are they talking about? But they're just talking to whether it's short acting or long acting. So albuterol this is like, I should put like 10 stars by it, because you know I'm going to ask you a question about what's a rescue inhaler, and then you need to know albuterol. So that is just something you absolutely will get tested on. And it's the kind of thing like if somebody has an inhaler with them, if they have very sort of, you know, just sort of like maybe more mild asthma, chances are they have a rescue inhaler and it's albuterol. And so that's like a big star next to that one. And then we have the long acting or maintenance. This is ones that people may just use at designated times during the day, you know, like every morning and evening, or I don't know how many hours in between, 12 hours maybe, or 8 hours. So these are your long acting, and these are the ones that you'll want to memorize. And they all work to just bronchodilate, right? So they're just trying to open up the airway because it's constricted, because it's been, you know, irritated or triggered, and so it's all working just to open up the airway. So what's a little bit more of the mechanism? So it acts on the beta-2 receptor, bronchodilation, most effective bronchodilators. So thus most of the medications are going to be beta agonists. Duration can be short or long. We already talked about that. The onset should be fast, especially if it's like a rescue inhaler, but it could be longer if it's a maintenance. It might take longer, but once they're sort of in a regimen, then it would be acting all the time, you know. And then, of course, we do have adverse effects of xerostomia, increased heart rate. So it can increase the heart rate or the contractility of the heart, nervousness, tremors, and that can be more with the short acting. So, you know, they just have to adjust different types of medications depending on if somebody has a lot of side effects, you know, for these. And I thought I had, oh, no, hold on, sorry, back up. I thought there was another adverse reaction that I had added, but I guess not. Okay. All right, so then the next category of drugs is the corticosteroids. These tend to be more maintenance or controllers. So usually somebody that has a more severe type of asthma or COPD would be using a corticosteroid for the chronic inflammation. And so it blocks the inflammatory response. So there's a whole series, your body, once you activate your inflammatory or your immune system, there's a whole series of receptors that can be triggered, and a lot of them will cause inflammation if they're just keep being triggered. So it kind of blocks this flow, this cascade of reactions, and it can go from a low, medium, or high potency. So it's just going to totally depend on the patient, how much they need, you know, and what kind of medication they use. So that's why you will have to memorize certain medications, but it would really truly be crazy to make you memorize all the different possibilities that are out there for medications. Yeah.
What's the 2 or 3 maintenance agonists that you listed earlier, or last slide? Are those considered corticosteroids?
These ones here?
Yeah.
No, these are only beta agonists, but you will see later we have combination that are beta agonists and corticosteroids, and those come up, I think, in a few slides.
So a patient might take either or both.
Yeah, a lot of times if the doctor feels like they need a corticosteroid, they'll give them one of these other formulated medications that contain both. I suppose they could give them separate, like they'd give them one of these and then they also give them a separate corticosteroid, but there are some combination drugs. So, I mean, that would just be up to the doctor really and what they want to prescribe. Okay, but for corticosteroids, we do know that you're going to see, because there's lots of different diseases and conditions that people take corticosteroids for. And so this will keep coming up in the different lectures, especially if somebody has maybe like an autoimmune condition that they have to take systemic corticosteroids for a long time. They're going to have more systemic side effects from the corticosteroids, but because they're inhaling these corticosteroids, they're going to be more susceptible to oral thrush or candida, the Candida albicans. So that's really important for you guys to know, because you'll be able to recognize that in somebody's mouth. Pharyngitis, so just inflammation in the pharynx. If they're taking a systemic corticosteroid for their asthma or COPD, like a pill, then they are going to have a little bit more susceptibility to these sort of bigger side effects. If it's just short term, they may experience things like insomnia, nervousness, increased appetite, or impaired glucose sensitivity. But if it's long term, then Cushingoid features, there's something called Cushing's disease. And so Cushingoid features would be some of the symptoms that go along with Cushing's disease. That's what that means. They might have some of those features. So it's not like they have the full-blown Cushing's disease, but they may have some of the sort of characteristics of the disease if they're on long-term steroids or long-term corticosteroids. Parchment-like skin, that's thin, crepey skin. Leg edema, swelling in the legs, sleep disturbance, poor wound healing. That's a big one for us because could affect periodontal disease. It could affect any wounds in the mouth. You know, if you do SRP, it might not respond as well. Impaired glucose, sodium and water retention, hypertension, osteoporosis, fractures, glaucoma, and depression. So a lot of systemic side effects that are really serious if somebody is on a long-term systemic steroid. And there are a lot of diseases or conditions where people have to be on them to dampen down the inflammation. So if it's an inhaled corticosteroid, so here you can see we have the combo. So if it's an inhaled steroid and it's only the steroid, then we have these medications here. But if it's long acting and it's a combination between the steroid, so it's a combination between the steroid and the beta 2. So that's what Advair is and Symbicort. They're combos. So I suppose someone might put someone on Pulmicort and then they might put them on one of our plain beta 2s, you know, but I don't know. I mean, that's something a doctor would decide. You know, I don't know the parameters for that, but I would think just so they don't have to deal with 2 different medications, I would think they would put them on a combo if they could. But it could have something to do with maybe they don't react well to something, so they try a different drug. I mean, there's all different reasons why they might choose to prescribe a certain way. But these are the options. Oh no, my battery's low. I have to hurry. I have 6 more slides. So leukotriene receptors, these are antagonists. So these are leukotriene blockers. These are used to treat asthma. So notice just asthma, not COPD. The mechanism of action is to block leukotrienes from binding to the receptors, and they can have side effects of headaches. The medication, I put Singulair as just the one that you need to memorize, even though there are others. And it seems as though that these are more of an oral maintenance medication as opposed to inhaler, from what I could see from what was available to me. So that is a different type. So that's not a beta 2, that's not a steroid, that is a leukotriene. So you'll want to separate that out so that you know we're talking about a different category of medication. And then we have the anticholinergics. These tend to go more with patients who have COPD. These are inhaler medications, and these block cholinergic receptors in smooth muscle. Sometimes I hate the way that it's written on these PowerPoints because it's not as intuitive to, but in the end, obviously what it's doing is opening things up, right? Because that's what you're trying to do. But it does this through a different mechanism of action, which is blocking cholinergic. So a lot of what we've talked about are adrenergic. We've talked about a lot of adrenergic receptors, but these block more of the parasympathetic or the cholinergic. Adverse effects, thankfully, there's low anticholinergics, but there still is anticholinergic effects. So they may have dry mouth, dry eyes, things like that. Nausea, an occasional metallic taste. And then the medications here, if it's short acting, there's Atrovent, and if it's long acting, Spiriva for the medications. And these do tend to be more for patients that have COPD. This is a summary. This came also from the textbook that I was looking at, and I just liked how it kind of summarizes things. Here's a summary on how the allergens react. Here's a summary on the histamine. If some of these you could probably ignore. SRS stimulates small bronchi. You can X that one out. I don't want you guys to get confused by stuff I didn't talk about. So some of this stuff you can ignore. If it doesn't show up on another slide, this is just talking a little bit more of the pathophysiology, but I did like these down here because the leukotriene, the mast cell, the sympathetic, and the corticosteroids, it sort of summarizes those types of medications. This one here we don't talk about, the theophylline. So I would just, I'm not sure how that fits in. So you could cross that one out. But these other ones, it just kind of gives a nice little summary. It's just a different way of looking at it. Sometimes when you get something from a different resource, just explains it in a different way, and sometimes it's helpful, sometimes it's not. So you don't, okay, that is, I don't know what happened on Tuesday. Maybe I didn't press refresh, but all that I did on Tuesday. So I guess maybe I didn't update it. So here's just another way to study for this. You put in the drug, put in the mechanism of action, MOA, mechanism of action. That's something you always need to know, and adverse effects. So these are just different drugs that you are responsible for knowing. So albuterol acts on beta 2 receptors. It's a bronchodilator. Adverse effects, it causes xerostomia and increased heart rate. And just do that for all the other ones. So here's a couple cases. So patient with moderate persistent asthma and allergic rhinitis, their current medications, they take daily vitamin, Centrum daily vitamin, loratadine or Claritin daily, and then they take Advair twice a day and albuterol once in a while. So since they're on Advair, what does that kind of put in your mind as to their level of asthma? Oh, it even says it in the question. But yes, more moderate persistent. So if they're on a maintenance, right? They're on a maintenance medication, and then they need the albuterol when things kind of like extra act up, right? So they're on a maintenance twice a day, they do Advair, and then they have their rescue inhaler if things are triggered even more. So what is the white buildup in the patient's mouth? You see some white buildup in the patient's mouth. What could that be? Thrush, candida, yep. So you could talk to them about that. I don't have it in this PowerPoint. I have it in special needs, and I should just add it to this PowerPoint because it's relevant. But they use those spacers. So if somebody is constantly using some of these inhalers that can increase their risk of thrush or candida, or even if it can just deliver the medication better, it gets deeper in the lungs, they have these little spacers. So they hook up their inhaler to the spacer, they dose the medication, it's in the little thing. And have you seen it, or they recommend it? Then in the lungs. Yeah. Quick. And it gets it, so instead of like Stephanie was saying, instead of the medication sort of diffusing in the oral cavity and maybe down in the throat, when they use these spacers, they get the dose in there and then they release it and take a deep inhale, and it gives it a chance to get down into the lungs right where they really need it. So I have pictures of it in the special needs PowerPoint for next semester. Oh, is there? Oh, good. I'm glad. Where is it? Oh, okay. Oh, it's in there. Okay, great. Well, and that's used quite often. So we talked about this. How can you? So when you counsel your patient on preventing rinsing their mouth, using a spacer, one of these dosing spaces, and then also after they use an inhaler to swish out their mouth with water. Those are some good things to encourage it, no matter what it is. If they say like, I have a bad taste in my mouth, or if they're getting the candida, the thrush. So those are good recommendations for a patient. Patient with asthma started running 3 to 4 times a week. They are having shortness of breath, likely out of shape. I don't know what this is an old case study. I'm going to rewrite it because I don't even know what the sentences are too short. I'm like, what are we trying to say here? But they started running and they feel like they're out of shape because they have this shortness of breath. But obviously they're asthma patients, so it could have something more to do with that too. Their current medication is Advair and Proventil or albuterol as needed, expired. So that might be a problem. And then Synthroid. What's Synthroid? Any throwbacks? Thyroid, good. Synthroid, levothyroxine, so they are hypothyroid. They take that once a day. And then Advair took more but there was no relief. So they were short of breath. They took their albuterol, they took more Advair, but there was no relief. So what's causing the symptoms? This is a little tricky. The running, yes. And I think what this is trying to get at is maybe their albuterol isn't working. So their albuterol, which would be like their rescue inhaler to really open things up. Yes, probably they're not used to running, maybe. That's certainly could be true. But if their albuterol is expired, maybe it's not potent enough and it's not giving them that instant bronchodilation. This is kind of a funny one. I don't know. Despite receiving a higher dose of Advair, why is it not effectively controlling the shortness of breath? So if we look back at Advair being a corticosteroid, and it also, and in the note it says exercise-induced asthma, so I'm sure that's probably a big part of it too. I can't get back to I've covered up my, I covered up my buttons to move my mouse, so it's like giving me trouble here. So the steroid is, maybe not doing it. It still has a beta agonist in it. So that case study I don't really know what the main point of it was, other than they need more beta 2 agonists to really get the lungs to like open up. And because their albuterol was expired, that's the only thing I can kind of derive from it. So I might rewrite that case study. I think every year I read that and I'm like, I don't like that one. And then I forget to update it. Okay, so that's it for today. So take home points take home things for the quiz for next week. Pay attention to anything that's highlighted in red or highlighted in yellow, or that I verbally said. Don't worry so much about things like etiology and prevalence, except for the asthma pathophysiology. You do want to know those things, that's pretty much the only pathophysiology that you really need to think more about. And then hopefully the quiz will be not a problem at all. Any questions? Extra credit. I'll throw in an extra credit. I know I haven't done that yet. I should throw in a couple. Throughout the semester, I'll throw in a couple points here and there. But you do get a lot of points. The assignment, that's what we'll talk about that. I'll talk about it next week because I'll have extra time with the guest speaker. But I did want to review the assignment with you, and the assignment and your study guides are very easy ways to get extra points. So even though the quizzes and exams are hard, because obviously there's a lot to study for, those are things that are open book on your time, and they're really a lot of points. It's like almost 60 points, I think, between the two of them, because one is 25, right? And one is 36. I can't remember. Yeah, that's 36 points, I think. I don't think it's 100. I think it's 36. And then your assignment is like 25, I think. So it's a lot of points. It's like an exam. And it's kind of like, there's no reason to not, it's good buffer. It's a good buffer. So that's it. Okay.